So, guys, gals, we left off with the pelvic girdle. We talked about how there are multiple bones in play. Before I forget, last Monday, yes, I know we already covered this stuff in class. Last Monday, someone asked me a question about fusing of bones. Question, comment? Yes. Before I give you your review question, I wanted to review the material briefly that the question's on. Last Monday, someone asked me about when fontanelles fuse, and I hemmed and hawed and said sometime between 6 months and 24 months. Yesterday, I was meeting with my child's pediatrician, and I put the question to the pediatrician and said, hey, when do fontanelles fuse? A student stumped me the other day. And my pediatrician first corrected me and said, fontanelles do not fuse in children. Instead, they close. They don't fuse until adulthood. So I'm telling you that now. Fontanelles do not fuse until adulthood. I'll get you in the back in a moment. But the pediatrician's answer for me is that fontanelles will close between 9 months and 16 months, depending on how large they were to start with and the child's nutritional conditions. In the back. Yes, we did. I will get to that in a moment. Question, comment? By close, as in it's no longer soft. So at about 16 months, there's no more soft spot, but the sutures haven't fully fused or formed yet. So we left off with the pelvic girdle last Wednesday. Within the pelvic girdle, there's a sacroiliac joint. And I need to camp on this one for a little bit here. There is some healthy debate in the field of anatomy and physiology about whether or not it's actually a joint. If you look in cadaver studies, the sacrum and the ilium, in most situations, are completely fused and immobile. And I'm bringing this up because Monday during lab, I was holding up the male and female pelvises, the real ones, and the sacrum fell off of the male pelvis. It completely disarticulated. So I thought that was a pretty interesting example of how it actually is a joint. In some people, in some individuals, they have this joint, particularly women that are at third trimester of pregnancy. They have a hormone called relaxin, which relaxes dense, regular connective tissues. In other words, it makes your joints very loose and flexible, which is helpful for giving birth. Speaking of giving birth, if you look at the pelvic outlet on a female pelvis, that pelvic outlet is quite large. Let's skip ahead a little bit here to gender differences. So as we look at the gender differences between the pelvises, male versus female pelvises, the male pelvis has a very small pelvic outlet. The female pelvis has a very large pelvic outlet. And in particular, if we look at that male pelvis, the pubic notch in the male pelvis is very tight and narrow. The notch in the female pelvis is very large, typically larger than 100 degrees, and that allows for the child's skull to pass through the birth canal or pelvic outlet. So let's make sure we are on the same page here. Did we ask this review question? All right. So here's our first review question. A newborn passes through what of its mother during birth? We have the obturator foramen, pelvic inlet, pelvic outlet, acetabulum, or the false pelvis. We're down to about 15 seconds. What is that opening called? So in terms of what a child comes out of, children typically come out of the pelvic outlet. And that's the word analogy I use to keep it straight. Think of pelvic outlet. That's how you get out of the pelvis. Question, comment? It does, doesn't it? The pelvic inlet's going to be up on top, pelvic outlet's on bottom. Really, the child has to go through both of them. So that's just a bad question. Don't worry about it. It's participation only. And it's not on your midterm exam. So guys, gals, let's focus on the femur. As we look at our femur, the femur is the longest and strongest bone of the body. Our femur is the most unique or recognizable long bone. If you've watched 2010 of Space Odyssey, the femur was the first weapon in that movie. If you think of the, you know what, I'm just going to stop. Most of you probably have never watched that movie. I'm dating myself. As we look at the femur, the head of the femur articulates with the coxal bone in adults. That coxal bone is going to be the ischium, the pubic bone, and the ilium fused together. And at that coxal bone, there's an indentation, a very large indentation referred to as the acetabulum. Here's some word history for you. The acetabulum in Latin means vinegar cup. Early on, early anatomists found that when these pelvic girdles or coxal bones would sit out, there would be fermentation as rainwater would accumulate in those acetabulums, and vinegar would form from fermentation. It's kind of gross sounding, but that's the word history or the name history of acetabulum. When we look at the head of the femur, there's a really big indentation in the head of the femur. That indentation is called the fovea capitis. Capitis for head, fovea for an indentation. And that fovea capitis allows for a very large ligament to anchor the head of the femur into the acetabulum. On our femurs, we have a greater and lesser trochanter. And as we look at these greater and lesser trochanters, one of the interesting things about them is that the greater and lesser trochanters, there's the greater, there's the lesser. Those trochanters of the femur are not present on newborn infants. They develop as we age, as our gluteus maximus, gluteus medius, and the other muscles of the gluteal region grow in size and strength. They'll pull on the bone, and the bone remodels to form the greater trochanter and the lesser trochanter. So that's going to be an age difference. You can age bones based on the size of those bony markings. We also have medial and lateral condyles. When we think of a condyle, I want you to think of a smooth extension that's used in a joint or used in an articulation. So if we look at the medial and lateral condyles of the femur, they are going to be distally located, and they are going to be here for the medial and right here for the lateral. Note in the figure they're smooth and white looking. That smooth bluish white coloration on the figure on the screen represents articular cartilage or hyaline cartilage at the end of the long bone. We also have epicondyles. And as we look at the epicondyles, epi means above. An epicondyle is directly above a condyle. Or another way of thinking of it is going to be directly proximal to the condyle. So our lateral epicondyle is right here. Medial epicondyle is right there. And as we look at the lateral and medial epicondyles, they don't have articular cartilage. Instead, they're rough. And they serve as attachment points for muscles and or ligaments. In between the two condyles, we have the intercondylar fossa. That's the smooth indentation between the medial and lateral condyles. And then finally, we have patellar and popliteal surfaces. The patellar surface is located distally and anteriorly and has some hyaline cartilage associated with it. That patellar surface is the articulation point for the patella, or the kneecap. The popliteal surface harkens back to the surface anatomy term. Popliteal is the surface anatomy term for the back of the knee, or the knee pit, as most students will call it. And that patellar surface, popliteal surface is the indentation on the distal posterior of the femur. When we look at the patella, the patella is a sesamoid bone. And I neglected to talk about sesamoid bones in the previous chapter. A sesamoid bone is a bone that's completely embedded in connective tissues, either tendon and or ligamentous connective tissues, so dense, regular connective tissues. I'll say that again. A sesamoid bone is completely embedded in dense, regular connective tissues. As we look at the patella, it's going to be on the anterior of the knee, also known as the kneecap. When we're born, the patella has not ossified yet. It's a piece of hyaline cartilage. And that's okay, because as the child is growing, they typically don't need a kneecap that early on in life. The patella will fully ossify typically by age 6 or a little bit later or earlier, depending on the dietary environment of the child and genetic components. As we look at the patella, we're going to have a tendon proximal to the patella and a ligament distal to the patella. Ligaments connect bone to bone. We're going to have a ligament connect the distal end, or the apex of the patella, to the tibia. And then we're going to have a tendon connect the proximal, or base of the patella, to the bones, or to the muscles of the quadriceps. The vastus lateralis, vastus medialis. We'll talk more about those after spring break. Up next, we have the tibia and the fibula. So we're going to be continuing to head distal down the leg. As we look at our tibia, the tibia is typically referred to as the shin bone. Something that's really worth emphasizing with the tibia is that is the only bone of the lower leg that supports your weight. You cannot walk if you have a broken tibia. However, if you break your fibula, the small bone of the lower leg, you can still support your weight and you can still walk. I remember being really confused about that when I was a student, the idea that someone could break a bone of their lower leg and continue walking. But then when you look at the structure and how the tibia structure allows for it to bear weight, it makes a lot more sense. We also are going to have medial and lateral condyles associated with the tibia and the fibula. The medial and lateral condyles of the tibia and fibula are often referred to as the ankle bumps. So when you're putting on your socks in the morning, you feel those bumps on your ankles. One's on the medial side, one's on the lateral side. That bump on the medial side is, I was getting ahead of myself. Those are the malleoli. The condyles are the articulation points that match up with the femur. The medial and lateral condyles of the femur are going to match up with the medial and lateral condyles of the tibia. One of the things that I found confusing as a student is typically when you look at a condyle will be paired with a fossa. The smooth extension is usually going to be paired with the smooth indentation, and it matches up really nicely. In most parts of the body, that's how it works out. Think of the temporomandibular joint. You have a condyle and a fossa being paired with each other. Or you have occipital condyles being paired with articular facets. If you look at C1 and then the occipital bone of the skull. A lot of students would ask me, how could we have two condyles directly next to each other, or paired with each other in the knee? And the answer is, there's a third player. And that third player is the meniscus of the knee. We'll talk more about that when we get to joints and articulations, but there's going to be a meniscus, or a chunk of fibrocartilage in the knee, with an indentation superiorly and an indentation inferiorly. And those two indentations are going to receive the condyles of the femur and the condyles of the tibia. There's also a very large, rough extension on the proximal anterior border of the tibia, known as the tibial tuberosity. This tibial tuberosity is going to be the attachment point of the patellar ligament. We also have the anterior border. This anterior border is a very sharp ridge, and it's a key component for identifying if you're looking at a left versus right tibia. Typically, when I'm trying to identify left versus right tibia, I first try to find the medial malleolus, and then I try to find the anterior border. Those are the two landmarks I really look for. And then once I find those two landmarks, I can figure out, is it a left tibia or is it a right tibia? And then finally, we have the bump on the inside of our ankle. We have the medial malleolus on the tibia, and then on the next slide, we'll talk about the lateral malleolus on the fibula. So as we look at the fibula, that is the small bone of our lower leg. The fibula does not bear any body weight. As we look at the fibula, it can be difficult to differentiate the head from the lateral malleolus of the fibula. The key things that we need to look for is that if there are indentations on it, that end of the fibula is going to be the head. And if we look at the lateral malleolus of the fibula, our lateral malleolus of the fibula is more rounded in appearance and has a smoother transition for the fibula. If you're trying to differentiate distal and proximal on the fibula. No, you do not need to do that in lab. You also do not need to differentiate left versus right for the fibula in lab. It's a little bit difficult to do that. Now, if we look at the tibia and the fibula, we have a special membrane that keeps them connected to each other. That membrane is called the interosseous membrane. An interosseous membrane is a super generic term if you look at the words associated with it. Inter means in between, osseous means bone. It's the in between a bone membrane, or interosseous membrane. Let's move on to our foot and ankle. When we look at the bones of the ankle, those bones of the ankle are referred to as tarsal bones. In lab, there are two specific tarsal bones that you need to commit to memory. The talus and the calcaneus, commonly referred to as the ankle bone and the heel bone. As we look at the calcaneus, this is the largest tarsal bone, and it forms the heel. So when you take a step, if you are a heel strike person for when you take steps or when you're running, you are going to be planting your calcaneus into the ground first. When we look at the talus is the most superior tarsal bone in the ankle. And I'll skip ahead a slide here. The talus is visible right here from a superior view, and it's also visible right here from a lateral view. The tibia rests on the talus, or the tibia of the lower leg will directly articulate with the talus. If I back up a couple slides here, we can see how on the tibia we have that curvature on the distal end. That curvature on the distal end of the tibia is where the talus sits. The talus fits into that curvature. We also have additional bones additional tarsal bones. You do not need to commit those to memory for lab. Those additional tarsal bones are going to be the cuneiforms. There's a medial, intermediate, and lateral cuneiform. Those are typically going to be the easier ones to commit to memory. And then there's also going to be the cuboid and navicular bones as well. As we're looking at the ankle and foot, the cuneiforms are going to be right next to each other. Medial is going to be in line with the big toe. Intermediate will be next, and then the lateral will be the third one. As we look at the cuboid bone is going to be the fourth or last bone of the distal row of tarsal bones. And then if we look at the navicular, our navicular bone is right here. I'm circling it right now. That navicular is a bone that is the third largest tarsal bone. So if we look at the tarsal bones and look at their size, the largest is the calcaneus, then we have the talus, and then we have the navicular. In terms of numbering the toes. The numbering system in the foot is identical to the numbering system of the hand. So in our hands, when we're numbering metacarpals and the phalanges, we start with 1 for our thumbs and end with 5 for our pinkies. Our thumb is analogous to our big toe. So when we're numbering the metatarsals and the phalanges of the foot, we'll have 1 for the big toe and then 5 for your pinky or small toe. Something worth emphasizing with the big toe is that our big toe has only 2 phalanges in it. The other toes of our foot will have 3 phalanges in it. And as we look at the big toe, also known as the great toe, sometimes I've even heard it referred to as the magnum toe, we have proximal and distal, the directional terminology for those appendages that are going to be applied. When we look at the other toes of the foot, since they have 3 phalanges, or phalanx for the singular, we are going to have the proximal and distal, and then for the one in between, we use the phrase intermediate, or excuse me, middle phalange. So, think back to those male and female pelvises. As we look at the male and female pelvis, what are some of the differences between the male and female pelvis? We have the male pelvis is more massive. The male pelvic outlet is smaller. The female pubic arch is usually greater than 100 degrees. The female coccyx is tilted posteriorly, or the female sacrum is longer. Last chapter, we talked about just general gender differences. Generally speaking, males have higher bone density. This is kind of a hard question. I'll give you 30 more seconds on this one. So how is the male and female pelvis different from each other? All of those options are true. So if we look at male versus female pelvises, the male pelvis is more massive. My pen exploded in my pocket. The male pelvic outlet is smaller. It's harder to get the skull of a baby through the male's pelvic outlet. When we look at the female pubic arch, it is greater than 100 degrees, whereas the male pelvic arch or pubic arch is going to be less than 90 degrees typically. As we look at the coccyx of the female, it's tilted posteriorly. In other words, the female's tailbone, instead of being tilted forward like the male's tailbone, the coccyx on a female will be tilted backwards or posteriorly to make more room for the child's skull as the child is passing through the pelvic outlet and inlet. And then the one thing that's the same between male and female pelvises is that the length of the sacrum, proportional to height, is going to be the same between males and females. So the sacrum doesn't change length between genders. So E was the correct answer, and that E is false. And I believe we are all done covering our material for your midterm exam.